Hello and welcome to this CME Symposium entitled From Delay to Damage, Changing the EGPA Trajectory with Early Diagnosis and Biologic Therapy. We are honored to have participants from around the world in attendance, not only in this room, but also viewing online. This program is provided by Integritas Communications and supported by an educational grant from AstraZeneca. A few important housekeeping notes for those of you in the room. To answer polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. Program information, presentation slides, and a link to valuable clinical resources are available in the workbook and on the postcard in front of you. To receive CME credit and as part of our ongoing efforts to evaluate impact and refine future activities, please complete and return the evaluation form before you leave. For everyone joining us online, the system will prompt you to answer polling questions, and the information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. For our live audience, please use the question cards located on your table to ask questions. Ushers will be collecting them throughout the program. If you are online, please submit questions through the Q&A box on the right side of your screen. Now, let's give a warm welcome to our presenters and enjoy the program.
Thanks for the warm welcome.
All right, I think we'll get started then. My name is Brian Strauss, everyone. I will be talking from delay to damage, changing the EGPA trajectory with early diagnosis and biologic therapy. Do you all want to introduce yourself?
I'm happy to introduce myself. I'm Mike Wexler. I'm a pulmonologist in a room of rheumatologists. I'm a professor of medicine at National Jewish Health in Denver, Colorado.
My name is Philip Seo. I am a rheumatologist, so I fit into this group. I am an associate professor of medicine at Johns Hopkins.
And I'm a rheumatologist locally here at Northwestern. These are our disclosures. And these are the educational objectives for today's talk. So we will start with a series of pretest questions. You have the clickers, I believe, at your table. So I will read the question and you can send in your answer. And then at the end, we'll review the answers in a post-test. So to start, approximately how many patients with EGPA do you manage each year? None, 1, 2 to 4, 5 to 10, greater than 10, or you do not manage patients. Okay, pretest question 2. Which of the following immune cells and cytokines play an integral role in the pathophysiology of EGPA and are a target of a currently available biologic therapy? Eosinophils and interleukin-5, neutrophils and interferon gamma, macrophages and interleukin-1, or natural killer cells and interleukin-3. Okay, moving on to question 3. In a patient who presents with eosinophilia and late onset asthma, which of the following is most likely to increase your clinical suspicion for EGPA? Hematuria, mononeuritis multiplex, otitis media, or a positive test for proteinase 3 anti-neutrophil cytoplasmic antibody? Question 4. In the phase 3 Mandara study, which of the following is true regarding the 2-year efficacy of benralizumab in patients with relapsing or refractory EGPA? Benralizumab was superior to placebo for induction of remission. Switching from benralizumab to mepolizumab enhanced blood eosinophil depletion and oral corticosteroid sparing. switching from mepolizumab to benralizumab enhanced blood eos depletion and corticosteroid sparing, or benralizumab was superior to reslizumab for induction of remission.
You know this one.
And now on to question 5. So Sarah is a 46-year-old woman. She has a 10-year history of asthma and was recently diagnosed with ANCA-negative EGPA. She is clinically stable on 150 milligrams of azathioprine, but unable to taper below 15 milligrams per day of prednisone. Which of the following would you recommend to Sarah at this time? Should she maintain her current medications, add a biologic with the goal of tapering prednisone, add a biologic and continue current medications, or start cyclophosphamide with the goal of tapering prednisone? Okay, and for question 6, approximately how often do you currently recommend biologic therapy for patients with EGPA? Never, 25% of the time, 50%, 75%, or 100% of the time, or you don't manage patients with EGPA. Okay, so thanks for completing the pretest. We'll move on now to the burdens and pathophysiology of EGPA, which I'm going to try to tackle for you all. So many of you probably know EGPA is one of 3 types of vasculitis that comprises the ANCA-associated vasculitis or vasculitides. EGPA tends to be the rarest of these 3, and you can see in this one reported study here the incidence of EGPA being 4 people per million per year compared to 13 per million and 16 per million for MPA and GPA. So this is a rare disease of a group of rare diseases. And all 3 tend to be characterized by autoimmune inflammation, particularly of small blood vessels, but occasionally medium-sized vessels throughout the body. And as is the case for many rheumatologic diseases, especially with vasculitis, we really want to catch these patients as early as possible, initiate treatment as early as possible, because left unresolved, this inflammation will go on to cause organ damage. This can, of course, be fatal and can cause complications that are, then irreversible with immunosuppressive therapy. In general, a large range of patients are affected by EGPA, but the median age or most common age patients are diagnosed is probably the 4th or 5th decade of life. On histology, you can see a necrotizing granulomatous vasculitis, often with eosinophilic infiltration. And again, this affects small blood vessels throughout the body, which you'll hear about more extensively in the clinical characteristics section. Distinguishing EGPA from GPA and MPA is important, and some characteristics that are particularly unique are the association with asthma, with more than 90% of EGPA patients having a history of asthma. So when I'm asked to consult or to see a patient with a query of EGPA and they do not have asthma, I weigh that pretty strongly. These patients are often likely to have nasal polyposis, which is a bit different even than GPA, which can cause, of course, sinus involvement. And as the E in the name suggests, peripheral eosinophilia is a hallmark of this disease as well. So this was a retrospective study of a group of allergy practices, and they asked patients to self-report, EGPA patients to self-report what symptoms they experienced during the course of their disease. And you can see here, there's obviously a lot of symptoms listed, but kind of the takeaway is that EGPA patients report a lot of symptoms across a wide domain or spectrum of their organ systems. And that ranges from a majority of patients describing things like fatigue and headache to actually every patient in this study reporting a rash. Gastrointestinal symptoms were very common. Respiratory symptoms were very common, with a vast majority experiencing wheezing, dyspnea, again, speaking to this association with asthma. A majority of patients reported some type of ENT type symptom, with again, virtually every patient reporting some kind of sinonasal symptom, and even things like cardiovascular symptoms being quite common in this group. So again, I think this speaks to the variety of ways EGPA can present and kind of the clinical suspicion needed because of all the different organ systems that can be involved. It's also probably worth pointing out that about a third of patients in this group reported symptoms of anxiety and depression, and we definitely see that mood disorders, anxiety disorders can be comorbid in these patients and are important to address also. From a continued kind of patient perspective, how does the diagnosis of EGPA affect our patients? And the answer is a lot of different ways. As you might imagine, having a rare autoimmune disease that's affecting multiple organ systems affects people's ability to do basic things that they want to do. They're reporting issues with their ability to work, to exercise, to sleep, to engage in social activities. And of course, then this becomes all intimately tied to those psychologic aspects of anxiety and depression that we saw on the last slide. Also kind of not surprising is that EGPA patients will self-report that a lot experience diagnostic delays. The stat here is a third, but I would say, especially in my practice, it's not unusual for patients to have seen several different physicians or even several rheumatologists before they get a diagnosis of EGPA, which again speaks to the kind of heterogeneity of the disease. But of course, these delays, these misdiagnoses are distressing to our patients. And the delays then translate into delayed treatment, which again, we worry about organ damage that no longer becomes reversible in those folks. And then patients with EGPA report difficulty accessing treatments, firstly because they may not have a proper diagnosis, but also because of the landscape of healthcare and the high cost of getting some of these treatments. Now, we'll cover this a little bit more in the clinical characteristics section, but kind of a broad overview as this ties into pathophysiology. So you can kind of think of EGPA a little bit as a spectrum between ANCA negative and ANCA positive disease, and I say that with a big asterisk. This isn't a black and white category. There's the reality is most EGPA patients fall in a gray zone somewhere between these things, but we do know that ANCA status in retrospective studies can inform particular risk for certain manifestations. And we see that ANCA-negative patients often have higher rates of more eosinophilic infiltrative manifestations, and that ranges from the things on the left-hand side of the slide here, like cardiac infiltration, lung infiltration, and gastrointestinal involvement. And then you see that ANCA-positive patients have a predilection or a higher likelihood in some of these retrospective studies of having vasculitic manifestations, so things like glomerulonephritis, mononeuritis multiplex, alveolar hemorrhage. Again, this isn't one-to-one black and white. ANCA-negative patients certainly can get some of these vasculitic manifestations and vice versa, but again, it can help kind of at least inform the risk, or when we approach a patient, what manifestations we might be looking out for.
Eosinophilic granulomatosis with polyangiitis, or EGPA, is a small vessel necrotizing vasculitis characterized by eosinophil-rich inflammation and extravascular granulomas that affects multiple organ systems. EGPA typically progresses through prodromal, eosinophilic, and vasculitic phases, though not always in the same order, and phases may occur simultaneously. About 30% to 40% of patients are myeloperoxidase ANCA positive. ANCA positive disease is more associated with vasculitis that is mediated by both neutrophilic and eosinophilic infiltration, whereas ANCA negative disease is thought to be mediated primarily by eosinophilic inflammation, leading to higher levels of eosinophil tissue infiltration. Both ANCA positive and ANCA negative EGPA share common features including asthma, sinus disease with nasal polyposis, eosinophilia, and eosinophilic or vasculitic features can occur regardless of ANCA status. Eosinophils are best known for allergic and antiparasitic responses, but in some forms contribute to tissue repair and metabolism. Activated eosinophils have pro-inflammatory effects that lead to tissue damage that is mediated through the release of different types of granule proteins in their cytoplasm. In EGPA, a form of programmed eosinophil cell death, known as eosinophil extracellular trap cell death, or EEtosis, has been observed and is thought to contribute to the development of vasculitis. Furthermore, the net-like structures formed during EEtosis have been linked to increased platelet adhesion and immunothrombosis. Interleukin-5 is a critically important cytokine in EGPA because of its multifaceted effects on the life cycle of eosinophils. IL-5 contributes to eosinophil differentiation and maturation in the bone marrow, migration to the peripheral blood and tissues, and prolongation of eosinophil survival. IL-5 stimulation, along with other factors, is involved in inducing EEtosis. Given the critical role of eosinophils and IL-5 driving EGPA pathophysiology, treatments that target both IL-5 and its receptor are now available and help improve patient outcomes.
Awesome. So that is a really nice segue and foundation to what looks like and can definitely be a very complicated slide. So breaking down the pathogenesis of EGPA, as you heard in the animation, and of course, again, based on the name, eosinophils are going to be a key player in mediating a lot of the inflammation and damage in this disease. And it's hypothesized that some allergen perhaps sets off the immune system, polarizing cells towards a Th2 or that kind of traditionally considered allergic type axis that then go on to produce a number of different cytokines downstream that activate eosinophils. And as you heard in the video and know potentially from therapeutics, interleukin-5 tends to be one of the primary cytokines that we think about, really in a bunch of different phases of eosinophil development, from differentiation from progenitors in the bone marrow to then leaving the bone marrow into the vasculature, and then all the way into exiting the vasculature and coming into the tissue to cause problems. And they do that through a number of kind of cytotoxic granules that you can see abbreviated here: the ECP cationic protein, major basic protein, MBP, all of these different inflammatory proteases or enzymes that go on to create inflammatory damage in the tissue. There are, of course, a number of other ways that these Th2 cells kind of activate the immune system in EGPA, and one of those is through B-cell stimulation. Thinking again about IL-5, but also other interleukins like IL-4, IL-13. And then B cells, of course, are responsible for antibody production, which kind of brings the ANCA or anti-neutrophil cytoplasmic antibodies into the picture here. They can go on to independently then activate neutrophils and further contribute to the inflammatory milieu in this disease. We also see B cells produce other antibodies, including IgE, actually IgG4, which has been looked at as a potential biomarker in EGPA. And then also contributing to the kind of granuloma formation and some of the vasculitic features of this disease, potentially as a response to eosinophil-mediated damage, you see another set of T cells kind of polarize into the Th1 or Th17 axis and release signaling molecules like interferon gamma that then go on to produce these granulomas that you can often capture on biopsy in some of these manifestations. So of course, having an intimate understanding of the pathophysiology then leads us to think about what potential therapeutic targets might exist, might work in EGPA, and what do we kind of have in our arsenal thus far in terms of targeted therapy. So on the left here, you can see that IL-5, again, interacts with the eosinophil at many different stages, and we have two kind of methods of targeting IL-5. One is targeting the receptor, and that is through the medication benralizumab. The other is targeting the cytokine directly through a monoclonal antibody, and that's things like mepolizumab, which is approved for EGPA, and then also reslizumab and depemokimab, which are not approved for EGPA, but other eosinophil-mediated diseases. You can think about the other interleukins that are involved, for example, in eosinophil trafficking, and that are things like dupilumab, which will block dual IL-4 and IL-13. And then going back to the B cell on the other side, are, as in rheumatology, our good friend rituximab blocking CD20 and leading to B cell depletion, or trying to target some of the antibodies that the B cell is making directly. And so we have omalizumab, which targets IgE. And so all of these are kind of, therapies that we will discuss, some more than others, and when we think about approaching the treatment of EGPA. So now a diagnostic challenge. Which of the following pathophysiologic clues is most suggestive of EGPA? Eosinophilia, neutrophilia, lymphopenia, or thrombocytosis?
I know this one too.
Perfect. I give all the credit to the whiteboard animation for that. Okay. So turning to you both, are there specific pathophysiologic clues that tip you off to EGPA when you're considering, a patient who comes to your office and thinking about making this diagnosis?
Yeah, I think it's so important to take a good history and look at the broad group of laboratory studies. And you have to really put the pieces of the puzzle together in terms of coming up with a diagnosis. You showed all the different pathways that are involved. It's also important to recognize the different pathways that are involved so that you can think about what your therapeutic approach is going to be. Is there ANCA positivity or not? That might guide you towards more of a B-cell targeted therapy. What's the degree of eosinophilia that you're going to see? Is there a significant component of allergies and other biomarkers as well that might guide you? But I think the key is really stepping back, taking a good history, and identifying eosinophils as a major player in this disease versus other vasculitides. You want to distinguish EGPA from both GPA and MPA in terms of vasculitis, but you also want to distinguish EGPA from other eosinophilic disorders. And particularly, you want to make sure that you're not missing out on either a drug reaction or a malignancy or some other kind of infection.
And the only thing I would add is both of us have a colleague, Bruce Bachner, who had been at Northwestern for many years, and before that was at Johns Hopkins. He was an eosinophil expert, and he said it should be illegal to get a CBC without a differential. Because many times the reason why EGPA doesn't come up in the discussion is because no one actually realizes that the patient has hypereosinophilia. So I think especially with a diagnosis like EGPA, the best thing you can do is just consider whether it's a possibility in a patient that's presenting, because you'll never make a diagnosis that you don't consider.
And if you don't look at the differential, that's another problem.
Well, yeah.
So the other take-home message is look at the differential,
Sure.
Look for eosinophils as well.
Awesome. All right.
So I'll be talking about diagnostic challenges associated with EGPA. And the first thing I'll do is I'll remind you about the phases of EGPA. So remember that traditionally we talk about EGPA as occurring in 3 different phases. The first phase is the prodromal phase. That's the phase that's associated with adult onset asthma. So picture a patient in the 30s and 40s, no real history of atypy previously, and then suddenly they get diagnosed with adult onset asthma. First, they're just using rescue inhalers, and then inhalers on a regular basis. And then finally, they get to the stage where they actually require systemic glucocorticoids on a regular basis to keep their respiratory symptoms under control. Phase 2 is the hypereosinophilic phase. That's the one that's associated with the fleeting pulmonary infiltrates that were first described in the ACR 1990 criteria. It's also associated with eosinophilic myocarditis. Patients can also have gastrointestinal involvement like eosinophilic esophagitis and eosinophilic colitis. Patients can also have cutaneous manifestations in the form of urticaria. We'll talk more about this in just a second. After that, though, patients develop phase 3. Phase 3 is the vasculitic phase. Now, technically, during the vasculitic phase, patients will look a lot more like microscopic polyangiitis to you. So these patients can develop pulmonary renal syndrome. However, the most common manifestation is probably going to be monorized multiplex, and that's the manifestation I'm going to be looking for most carefully when I'm thinking about EGPA. I will say there's an old saw that when a patient develops the vasculitic phase of EGPA, the asthma goes away. Like many old saws, that's not true. That is true for a small number of patients, and you might see it in your own clinical experience. But for the vast majority of patients that I manage, it's the sign of pulmonary symptoms, the EGPA, that continue to linger on after I get the vasculitis under control. With regards to specific manifestations, starting towards the bottom, remember with monorized multiplex, you can see mononeuritis with any form of ANCA-associated vasculitis, but it's so classic for EGPA that when a fellow presents a patient with monorized multiplex to me, the first question I ask them is whether or not that patient's wheezing. In terms of gastrointestinal involvement, remember that with eosinophilic esophagitis, the tip-off is going to be that the patient has GERD-like symptoms that don't respond to high-dose PPIs. That's when you're going to want to think about referral to GI for a biopsy in order to make that diagnosis. In terms of kidney involvement, it is true that patients can develop glomerulonephritis, just like microscopic polyangiitis, but it's going to be more common to see patients develop an acute interstitial nephritis from eosinophilic infiltration, like you might see in a patient who's taking NSAIDs for too long. In terms of neurologic involvement, I'll also mention that some patients can develop CNS manifestations, although that's relatively uncommon. In terms of dermatologic manifestations, you want to think about the etiology. So some patients will develop a palpable purpura due to leukocytoclastic vasculitis of the skin, just like they might develop from like IgA vasculitis, for example. And some patients will develop an eosinophilic infiltration, which will look just like an urticaria or an urticarial vasculitis to you on examination. In terms of ENT, nasal polyposis is classic for EGPA, and you're really expecting the majority of patients that you see presenting with EGPA as having nasal polyposis in addition to their asthma. In terms of vascular findings, digital ischemia can technically occur in EGPA. It's actually relatively uncommon. I'll just mention that even though you might think about EGPA, it's also important to think about the other cardioembolic causes of vascular ischemia, because one of those etiologies is probably more likely to explain vascular ischemia in that patient. And then in terms of respiratory symptoms, you're going to want to think about imaging the lungs in order to look for those fleeting pulmonary infiltrates that we always like talking about. If you're my vintage, you'll probably remember that years ago there were 2 papers published roughly simultaneously, one by a French group in ANR, one by an Italian group in Annals of Internal Medicine, that both made the same conclusion, which is that you can think of patients with EGPA in terms of either ANCA positivity or ANCA negativity. It's the ANCA positive patients that tend to look like the rest of the patients we might manage with vasculitis. So those are the patients who are more likely to develop palpable purpura, glomerulonephritis, and pulmonary hemorrhage, monorized multiplex. The patients who are ANCA negative are more likely to develop the features that you might associate with hypereosinophilia. So those are the patients you're going to be thinking about pulmonary lesions, cardiac lesions, gastrointestinal involvement, that sort of thing. And while that observation is statistically true when you look at large populations of patients, for the individual patient, it tends not to be all that helpful, and you'll again see a mix of symptoms in any given patient with EGPA. So you shouldn't look at the ANCA and think that you can predict what the clinical manifestation of that patient might be. In terms of common clinical presentations, remember that the majority of patients with EGPA will have asthma at presentation and will have hypereosinophilia. Rarely you'll see a patient who has normal eosinophils because they've been maintained on glucocorticoids continuously for so long. No one actually has a lab test that predates them being treated with like 10 milligrams of prednisone. And in that case, you might have to do a little bit of digging in order to find that evidence of hypereosinophilia. But in general, if you don't see hypereosinophilia, that patient more likely than not doesn't have a diagnosis of EGPA. We mentioned also about nasal polyposis being an important tip-off to a diagnosis of EGPA. So when a patient comes into your clinic with both asthma and nasal polyposis, you definitely want to think about EGPA, at least in passing. In terms of evaluation, remember when you see a patient with monorized multiplex, you definitely want to think about getting a nerve conduction study. But remember that that feature needs to mature before you can get that nerve conduction. So if that patient developed monorized yesterday, and by some miracle you got that patient to your clinic today, it is too soon to get that nerve conduction study. It probably will not end up being helpful until a few weeks have passed. In terms of renal involvement, I love kidney biopsies because they're both diagnostic and prognostic. For patients who have got glomerulonephritis, you can not only confirm the diagnosis, but you can also tell them what their renal outcome is going to be. It is very rare to have a biopsy that can give you so much information all at once. In terms of gastrointestinal symptoms, there are radiologic features that in the days of the giants we used to use in order to make a diagnosis of eosinophilic esophagitis or colitis. I will say nowadays, more likely than not, you're going to send them to a gastroenterologist just to do a biopsy and look under a microscope in order to make a diagnosis of one of these features. In terms of ENT involvement, I honestly find nasal biopsies to be kind of useless. And it's because when you have nasal polyposis is basically just big sacs of eosinophils, and the same sacs of eosinophils exist in EGPA patients as occur in patients who have got allergic symptoms. So I don't find it terribly diagnostic. I think those biopsies might be more useful to rule out other diagnoses that you might want to consider. Allergic bronchopulmonary aspergillosis is mentioned on the slide as part of the differential diagnosis. Remember that you're going to think about that in patients who have central bronchiectasis, which is not a feature of EGPA. So if you see that, you're going to think about ABPA first. With purpura, even though you can technically make the diagnosis based on morphology, I think it's always valuable to consider doing a biopsy. Normally, you biopsy a vasculitis patient, you're asking the dermatologist to do 2 biopsies at once. The first one for H&E, for morphology, to prove that the patient has vasculitis. And the second one for direct immunofluorescence to make sure that that vasculitis is pauci-immune, meaning there's no immunoreactant deposition in the walls of the vessel. That's much more consistent with an ANCA-associated vasculitis. The reason why you want to consider it is not necessarily because you're doubting the diagnosis now, but you might doubt the diagnosis 5 years from now, by which time the patient's been treated with so much steroids that the skin biopsy ends up being non-diagnostic. So it's helpful to get that information up front while the patient's still fresh. All hypereosinophilic syndromes can affect the heart, and that heart involvement is deadly. So remember, in the United States, the most common cause of cardiac dysfunction is going to be cardiovascular disease. In Africa, the most common cause is going to be eosinophilic myocarditis from parasitic infections. So these eosinophils are nasty buggers, and they have a tropism for the heart. If you, in any patient who's presenting with an idiopathic hypereosinophilic syndrome or EGPA, you want to get an echocardiogram at least once. You're going to think about an eosinophilic myocarditis if you see that global hypokinesis, and especially if you see an intracardiac thrombosis. In terms of CNS manifestations, actually, they're reasonably uncommon. I will say there's a number of CNS manifestations that are relatively broad, including cranial nerve deficits and hemiparesis that can present as part of EGPA. So if you see that in an EGPA patient, just remember that they may be linked to that patient's primary rheumatic diagnosis. And then there are other abnormalities that we'll talk about in the next slide. These are the 2022 ACR/EULAR classification criteria for EGPA. I am mandated by my union to remind you that these are classification guidelines and not diagnostic guidelines. So these guidelines are really only meant to be applied to patients who have already been clinically diagnosed as having a vasculitis. And the purpose is to be able to differentiate EGPA from other forms of vasculitis. That said, from a clinical standpoint, I find them to be a useful mnemonic because it reminds you about what features might be important to help establish a diagnosis of EGPA in a patient that you might see in clinic. Starting towards the bottom, remember that PR3 ANCA positivity is really a feature of GPA rather than of EGPA. So if you think a patient has EGPA, but they're PR3 ANCA positive, probably they have GPA and they just have a little bit of asthma. They probably don't have a real diagnosis of EGPA. In terms of hematuria, that's just to point out that classic glomerulonephritis is less commonly associated with EGPA than it is with MPA or GPA. Not to say that it can't occur, just that it's less common. We also mentioned previously that monorized multiplex and nasal polyposis are really typical for patients with EGPA. So seeing those clinical manifestations really should make you think strongly about an EGPA diagnosis. This is the differential for hypereosinophilic syndromes. You will all be relieved to know I will not be going through every single diagnosis on this slide one by one, but let me make a couple of points. The first is that typically when you see a patient who is being evaluated for EGPA, you're often trying to differentiate it from patients who have an idiopathic hypereosinophilic syndrome. So they're going to have eosinophilia and evidence of other organ damage. The easiest way to make this differentiation is patients with hypereosinophilic syndrome tend not to wheeze. So it's a good tip-off that that patient is probably going to have EGPA if that patient has hypereosinophilia, organ damage, and also has severe asthma. It's not 100%, but it's a good way to start sort of categorizing these patients in your head. When you see those super high levels of eosinophils, I think all of us think about eosinophilic leukemia, but eosinophilic leukemia is actually as rare as hen's teeth. So you're going to try to make that diagnosis a lot, but you're not going to. Instead, that patient's probably going to have a parasitic infection, which really drives eosinophils to very high levels. So you want to think about parasites, and in particular strongyloides. Remember that the commercially available test for strongyloides is really bad. So if you have a patient who presents with hypereosinophilia and has been hiking barefoot in the Appalachian Mountains, you should probably treat empirically rather than waiting for that blood test to come back. I'll mention mastocytosis because mast cells and eosinophils are like peanut butter and jelly. They always appear at the same time. So if you're just looking at the eosinophils, but this patient has mainly cutaneous disease, you might want to also think about the possibility of systemic mastocytosis in that patient. Over on the right-hand side, the very right panel is just a reminder that you can see mild hypereosinophilia in basically all of our diagnoses. So if you see a patient with lupus who has a little bit of hypereosinophilia, that patient does not have EGPA, they have lupus with a little bit of eosinophilia. In terms of other diagnoses you might run into, Gleick syndrome is a diagnosis like pheochromocytoma that you'll spend a lifetime looking for and may never find. Gleick syndrome is hypereosinophilia with angioedema. So you're going to see a patient who presents to the ER who has dyspnea. They're going to have significant peripheral edema, and they're going to have hypereosinophilia. And then as you're debating with ID and hematology and oncology about what to do about the patient, suddenly the patient's going to diurese 10 pounds and their eosinophils are going to drop and the patient's going to want to be discharged. It's the most interesting phenomenon. It's incredibly rare, but the reason why you want to think about it is it's a benign form of hypereosinophilic syndrome. So patients who have this disease, they don't actually suffer end organ damage. It's actually a benign phenomenon. I think that's all I want to say about this slide. When you think about EGPA, remember you're thinking about it as the confluence of two different diagnoses. You're going to think about a patient who has a combination of both an ANCA-associated vasculitis and an idiopathic hypereosinophilic syndrome. And the way that the patient presents clinically is really going to depend on whether or not they lean more towards those vasculitic features or when they lean more towards those hypereosinophilic features. In terms of distinguishing the diagnoses, probably the easiest way, again, is these nasal polyposis and the asthma, which is classic for EGPA, less commonly associated with GPA and MPA. On the other hand, true necrotizing glomerulonephritis is much more characteristic of GPA and MPA, less commonly found with EGPA, although it's not impossible. I'll also mention that the necrotizing granuloma that you see with GPA is very distinctive and can easily help make a diagnosis of GPA and will look very different to you on biopsies than EGPA. In terms of clinically approaching these patients, and we'll talk more about this a little bit later, we think about patients having either severe or non-severe disease. Severe disease is defined as a disease that threatens life or the function of a vital organ. So again, we're thinking about pulmonary renal syndrome or monorized multiplex. Non-severe is kind of the other manifestations that you might see with EGPA. These are some of the key definitions that we use when we're talking about EGPA. Of course, the goal of treatment is to get patients into remission, so the absent disease activity, which often requires some low dose of glucocorticoids, but the goal is to try to get them off therapy if possible. The last thing I'll mention is the 5-factor score, which ironically has 4 factors. So the 5-factor score consists of age older than 65, cardiac insufficiency, renal insufficiency, and gastrointestinal involvement. The reason why I say the 5-factor score has 4 factors is that the last factor is a negative factor. So having that ENT involvement is a negative point. So if you have a patient who's older than 65, but also has ENT manifestations, that patient's 5-factor score is 0. which is good because if your 5-factor score is 1, then your mortality is 20% over 5 years. So it's a mortality index, and it's very good to help us determine what the long-term prognosis of an EGPA patient or a patient with ANCA-associated vasculitis might be. So now we've got a diagnostic challenge question. In your opinion, which of the following is the most critical red flag sign prompting EGPA workup? Eosinophilia, late onset asthma, not finished, palpable purpura, glomerulonephritis, or none of the above? Now you can cue the music. Okay.
So, in terms of red flags that prompt an EGPA workup, we talked about eosinophils as being one of the key ones. What are some of the other things that you think of, Phil, in terms of big red flags?
Oh, as I mentioned before, I really think a monorized multiplex is for us as rheumatologists, is to be a key feature of EGPA. And I mention it because these patients will come to us from neurology. Well, they'll know the patient has monorized multiplex. They won't necessarily have done the clinical history to determine that EGPA is the most likely etiology.
What are your thoughts?
I definitely agree there. I think also, from a rheumatology perspective, when I'm seeing a patient, I don't see a lot of patients that come to me for asthma, and it's not, I'm not a pulmonologist, but when someone has an adult onset asthma, it's worsening over time. It's becoming more difficult to control. They're now needing hospitalizations for their asthma. They're needing further inhaler control, more steroids. I look pretty carefully in those people for other features, other organ systems, other manifestations that might clue me off to EGPA. In addition to just having that worsening asthma feature.
And one other question I have for you guys is, you mentioned, Phil, that patients who have PR3 positive features, PR3 positivity and features consistent with vasculitis, who happen to have eosinophilia, you'd classify them as GPA. But if they've got significant eosinophilia, isn't that the E of EGPA?
That is true. I will say that if you look at large populations of patients, that patients who are PR3 ANCA positive, they typically look more like GPA than EGPA. So I think that if you follow these patients long term, you're going to find that the eosinophilia is more of an epiphenomenon than it is actually a pathologic thing that you need to treat. Most of the times that I see this, the eosinophilia that you see in these patients is actually pretty low grade. Also, if the patient has necrotizing granuloma, I think we're basically obligated to consider them as GPA, and we would use more GPA strategies like rituximab or methotrexate.
Interesting. Great. So, we've talked a little bit about the pathophysiology. We've talked about the clinical features of EGPA. Let's talk a little bit about the evolving management strategies. And we'll start off by talking a little bit about the importance of individualizing care for these patients. We're in an era now of precision-based medicine, and we want to give the right drug to the right patient at the right time. EGPA in particular is quite a heterogeneous disease, and there are some patients who have more of an eosinophilic phenotype, other patients who have more of a vasculitic phenotype, and the clinical course can be quite different for those different kinds of patients. There's also the factors that there are many different organs involved in these kinds of patients, and there are also constitutional symptoms that are quite prevalent in this patient population. The disease severity can also vary. You might see patients who have alveolar hemorrhage and require ventilatory support, and you might also see patients who just have really bad asthma with pulmonary infiltrates with a skin rash consistent with the palpable purpura, for instance. And so that heterogeneity of presentation can be quite important in terms of how you're going to go about treating these patients. The other important thing to recognize is that patients will respond very differently to different treatment approaches. And you want to be somewhat thoughtful in terms of giving the right drug to the right patient, because if you give, for instance, a B-cell targeted therapy in someone who's got relatively low levels of ANCA positivity and high levels of eosinophils, they may not respond to the same degree as if you might target the eosinophils, for instance, in those patients. The other important component, and this has become a little bit less of an issue over time, but it's recognizing all the morbidity associated with glucocorticoid use. And you as rheumatologists all recognize that there are both acute effects of glucocorticoids as well as chronic effects of glucocorticoids. And one of our major goals in the management of these patients is to really minimize glucocorticoid toxicity. We want to minimize the acute exacerbations that result in weight gain, anxiety, poor sleep, hypertension, risk of infection. But we also want to prevent some of the long-term complications that are seen in patients who are chronically on glucocorticoids, including cataracts, glaucoma, osteoporosis, risk of cardiovascular disease, and many of the other things that are listed here. So we want to try to prevent both the short-term and long-term effects of glucocorticoids. The management of EGPA has evolved substantially in the 75 years since this entity was first described by Jacob Churg and Churg-Strauss in the early 50s. Early on, mortality was quite high, and over 70% of patients died within months until people started to recognize the importance of using glucocorticoids. Systemic glucocorticoids had a significant impact in terms of managing the disease and survival, but were associated with significant adverse effects. In the 70s, up until the early 2000s, we started to give more of an immunosuppressive strategy to our patients, offering them cyclophosphamide, particularly for more severe patients, interferon alpha in particular was utilized in these patients, methotrexate, azathioprine when people were coming off of cyclophosphamide, mycophenolate as well. And then in the last decade or so, for ANCA-positive patients, rituximab was increasingly utilized, similar to how it's utilized in other ANCA-associated vasculitides. However, in the last several years, in the last 8 years or so, we've started to recognize the importance of targeting the eosinophils. And back in 2017, 2018, mepolizumab was approved for the management of EGPA. And then last year, in 2024, benralizumab was approved for the management of EGPA. Here are these two therapies, and they're somewhat different in terms of their effects. Mepolizumab targets interleukin-5, the ligand, whereas benralizumab targets the IL-5 receptor. By doing so, not only does it prevent IL-5 from binding to its receptor and activating eosinophils, but also the eosinophils can be more dramatically depleted through a mechanism of antibody-dependent cell-mediated cytotoxic effects that can result in the depletion of eosinophils, not just the reduction of eosinophils. That being said, mepolizumab has been approved since 2015 for the management of eosinophilic asthma. It's been approved as well for chronic sinusitis with nasal polyps, as well as hypereosinophilic syndrome. And more recently, earlier this year, it was approved for the management of COPD with an eosinophilic phenotype. Benralizumab was approved in 2024 for the management of EGPA, and back in 2017, it was also approved for the management of eosinophilic asthma. It's also being studied in other eosinophilic conditions, including the hypereosinophilic syndrome, as well as chronic sinusitis with nasal polyps. Now, in terms of the efficacy of these therapies, the first study that led to the approval of mepolizumab, or the first anti-IL-5 therapy, was what was called the MIRA study, mepolizumab in relapsing or refractory EGPA. This study took patients who had relapsing or refractory EGPA and randomized them to 300 milligrams of mepolizumab on top of their standard of care therapy versus placebo, with the goal of identifying the proportion of patients who were able to achieve remission and the proportion of patients who had a relapse, as well as looking at steroid-sparing effects. As can be seen in the left-hand panel of this slide, you can see that there was a much greater proportion of patients treated with mepolizumab, around 30 to 35% of patients, compared to patients who were treated with placebo on top of either steroids with or without other immunosuppressants, which was only around 3% of patients. So about a tenfold increase in the proportion of patients who were able to achieve remission. Remission was defined as able to get down to 4 milligrams or less of prednisone and having a Birmingham vasculitis score of 0. In addition to the benefit in terms of achieving remission in this patient population, in the MIRA study, there was a much greater proportion of patients who were treated with mepolizumab compared to those treated with placebo who were able to be relapse-free. As you see in this Kaplan-Meier curve on the right-hand side of this figure, about half as many patients ended up having a relapse with mepolizumab compared to placebo. In the more recent Mandara trial, this is a study that we published in the New England Journal of Medicine just a year ago in 2024, we did a head-to-head comparison, comparing benralizumab on a monthly basis with mepolizumab 300 milligrams on a monthly basis. You should note that these are different than the doses utilized in asthma, but for EGPA, because it's more of an eosinophilic disorder, we used a bit of a higher dose for each of these therapies. And what we demonstrated was that benralizumab was non-inferior to mepolizumab in terms of the proportion of patients who had relapsing or refractory EGPA. It was non-inferior in terms of its ability to induce remission in patients with relapsing or refractory EGPA. You can see that the two lines, the red and green lines, basically overlap with one another. We recently published the 2-year efficacy of anti-IL-5 therapy in patients who participated in the Mandara trial, who were switched at the end of 1 year from mepolizumab to benralizumab. And what we demonstrated was that starting at week 52, when patients were switched over from mepolizumab to benralizumab, the proportion of patients who were able to have complete withdrawal of oral glucocorticoids, as seen in the right-hand figure of this slide, was able to be achieved to a comparable degree once patients were switched from mepolizumab to benralizumab. In the initial trial, at the end of 1 year, mepolizumab didn't do quite as well as benralizumab in terms of complete withdrawal of oral glucocorticoids, as I'll show you in a subsequent slide. 41% of benralizumab patients versus 26% of mepolizumab patients were able to come off of glucocorticoids completely. You should know that prior to the initiation of these anti-IL-5 therapies, in the placebo arm of the prior MIRA trial, only 3% of patients were able to come off of glucocorticoids. So now, instead of 3%, with benralizumab, we're getting 41%, and mepolizumab, 26% of patients off of glucocorticoids. In terms of steroid-sparing benefits, in the phase 3 MIRA trial, what we demonstrated with mepolizumab was that patients treated with mepolizumab versus placebo were able to cut their glucocorticoid dose in about half. Patients treated with mepolizumab started off at around 11 milligrams a day and got down to about 5 milligrams a day, whereas patients treated with placebo only started off at 10 milligrams and ended up at 10 milligrams. So there was about a 50% reduction in glucocorticoid dose in this patient population. In the head-to-head Mandara trial, in which patients received either mepolizumab or benralizumab, you can see on the left-hand panel that in terms of proportion of patients who were able to have a 50% reduction in oral glucocorticoid dosing, 85% of patients treated with mepolizumab and 74% of patients treated with mepolizumab were able to achieve a 50% reduction in glucocorticoid dosing. When we look at 100% reduction in glucocorticoid dosing, we again see here the 41% of patients treated with benralizumab, 26% of patients treated with mepolizumab were able to come off of glucocorticoids completely. And when we look at the proportion of patients who are able to get down to 4 milligrams or less, it's around 69% in the two groups. Both of these drugs, mepolizumab and benralizumab, are safe. They're both effective. They're not immunosuppressive in any significant way. And yes, there were a number of patients who had adverse events in these trials, but nothing really unexpected and no significant risk of serious adverse events in these small study population. You should note that this study occurred during the COVID pandemic. The most common adverse events was the occurrence of COVID, 21% and 27% of benralizumab and mepolizumab patients, but otherwise commonly seen adverse effects in patients who participate in clinical trials were observed. And no patients in the benralizumab arm and 3 patients in the mepolizumab arm discontinued therapy due to adverse events. So let's do a diagnostic challenge. Fun, fun, fun. Anne is a 48-year-old woman who has a 7-year history of asthma and a 2-year history of chronic rhinosinusitis with nasal polyps. In the past month, she's experienced worsening asthma, necessitating an emergency room visit, and she reports a persistent cough, fatigue, and a rash that looks like purpura on her bilateral lower extremities. Her lab results showed significant hypereosinophilia with a level of 2,496 cells per microliter, and this led to a diagnosis of EGPA. She was currently on prednisone 10 milligrams a day, along with inhaled corticosteroids and a long-acting beta agonist. Which of the following would you recommend at this point? Would you continue her current medications? Would you discontinue prednisone and add a biologic? Would you continue your current medications and add a biologic? Or would you discontinue prednisone and start cyclophosphamide? What are your thoughts? Great. So the vast majority of you got the correct answer, which is to continue current medications and add a biologic. You don't want to taper the oral glucocorticoids too quickly because they may develop complications of the disease and or adrenal insufficiency. So adding on a biologic can help facilitate glucocorticoid withdrawal. Let's talk a little bit about adding biologics to glucocorticoids. What are your thoughts in terms of this important approach and which biologics to consider? When do you consider adding a biologic? What are the circumstances?
Sure. I would say I'm quite aggressive with adding IL-5 therapy to corticosteroids, in pretty much all comers at this point who have non-severe disease because of the risk of relapse with steroid monotherapy alone. I'm talking about discussing with the patients adding an IL-5 agent between mepolizumab and benralizumab. It's a little bit of an insurance game. If I have my way, I usually start with benralizumab because of the potential more significant EO depletion and quicker onset. And I'm doing that, as you mentioned, from the study data because I want to avoid steroid toxicity in these patients. I want to give them a better chance of getting off steroids, and we know how relapsing and recurrent this disease is. I think, when you get into severe disease, which was excluded, from the Mira and Mandara trial, that becomes a more complicated question about induction with cyclophosphamide rituximab up front, and then when to switch, or whether you add on IL-5 therapy later on. And I think that will probably come up in some of the cases that we get into.
So Phil, if you have a patient who presents with ANCA-positive, myeloperoxidase positive, EGPA, and has significant eosinophilia with an eosinophil count of, say, 3,000, how do you decide between offering that patient rituximab or an anti-IL-5 therapy? And can you give both? How do you make that decision?
Yeah, I don't think it's an either or. So I think that if the patient has sinopulmonary manifestations that are mediated by eosinophils, I'm definitely going to give interleukin-5 receptor or interleukin-5 blockade. I think if the patient has classic glomerulonephritis, pulmonary hemorrhage, monomerized multiplex, I'll probably also give them rituximab. I don't see a problem giving both. I think that interleukin-5 is really only used to defend yourself against parasites. So I tell my patients, don't go swimming in the Ganges, don't go walking barefoot anywhere, and I think that they can do without interleukin-5 and still live very fruitful lives.
And what about the risks of rituximab in terms of immunosuppression? We saw during the COVID pandemic that there were concerns about giving patients rituximab in terms of preventing uptake of the vaccines, for instance.
Yeah, and I don't want to discount that. Certainly of all the immunosuppressive drugs that we've used during the pandemic, rituximab is the one that's associated with truly worsening outcomes from COVID-19 infection. It's the reason why we segregated out specifically for patients we would call severe disease. So if you have pulmonary renal syndrome, you really don't have a choice. You're going to need to be treated with either rituximab or cyclophosphamide, and of those two, rituximab is still the safer choice despite the association. There's this ridiculous study, by the way, that looks at all the immunosuppressive drugs that we use in rheumatology and notes that there's not an increased risk of COVID-19 associated with cyclophosphamide treatment. It's because like 2 patients in the study got treated with cyclophosphamide. That's not a real phenomenon. Remember that cyclophosphamide basically eliminates both B cells and T cells. There's no way you can think of it as a safer drug than rituximab is.
And I'm just going to make one other point in comparing benralizumab versus mepolizumab. Some of the things that come up in terms of my discussions with patients, and yes, payers play an important role, but one is the greater depletion of eosinophils that you mentioned. And another is the fact that with benralizumab, you have fewer injections. It's only a 1 monthly shot versus 3 monthly shots with mepolizumab. So patients might have differing opinions. On the other hand, mepolizumab has been approved for a longer period of time, and so there might be a different comfort level in that regard. So great. So let's talk a little bit about comprehensive EGPA care. This is an important question, and here I am as the pulmonologist and rheumatologist. So what are your thoughts in terms of the differential roles of rheumatologists versus pulmonologists versus allergists in terms of the diagnosis and management of EGPA? Who wants to go first?
I'll take this one. So I think I've known Mike for a long time. I think Mike would be just as happy if we just prescribed cyclophosphamide and shut up. That said, I really think it's very regional. If you look at the people who manage hypereosinophilic syndromes, it's actually all over the map. Some of the experts are actually infectious disease specialists. Some of them are allergists, immunologists. Some of them are rheumatologists, pulmonologists. But it really depends on who in the area is taking ownership of these patients. So I think when it comes to making a primary diagnosis, you're going to find in your local area that different physicians may be more or less comfortable with this, and it may matter a little bit less as to what their primary expertise is. But I think as the expression goes, it takes a village. You'll find with these patients, they often have multiple organs involved, and you'll find that you really need the assistance of multiple specialists in order to make sure that the patient's getting the best possible care.
Yeah, I think it's important. I think the way you have to think about this type of disease, which affects multiple organ systems, is it really requires a team of specialists. And you're going to involve the ENT doctors, you might involve other specific organ-targeted specialists as well. And oftentimes you also have to involve an endocrinologist to help manage the glucocorticoid withdrawal and some of the adrenal insufficiency. Any other perspectives?
I agree, and I say, that's the beauty and why I personally really enjoy working at a vasculitis center. It's, patients always ask me what makes this a center, what makes the vasculitis center, and it's really, it's not necessarily the rheumatologist, it's the team of people, right? It's that I have my go-to ENT colleague I can message and get people in quickly if they have, a new finding that needs biopsying or scoping. It's that I have a nephrologist, on the team who's familiar with this diagnosis. So I think, again, as a rheumatologist, some of what comes into play in our center is a little bit of like quarterbacking and trying to, help the patient make sure they get to the right place. But I completely agree. It's a team approach.
Okay, great.
Oh, this is me. So the ACR Vasculitis Foundation released guidelines for the treatment of ANCA-associated vasculitis, including EGPA, back in 2021. Admittedly, this is getting a little bit long of the tooth, so some of the recommendations that should probably be updated and hopefully will be in the near future. That said, remember that we think about patients as having either severe or non-severe disease. So for patients with severe disease, the recommendation is treat with either cyclophosphamide or rituximab. Again, we're thinking about patients with monorace multiplex pulmonary hemorrhage, glomerulonephritis, diagnoses that get the most aggressive therapies that we have to offer. For patients with non-severe disease, I think you have more alternatives, and the way that you should think about these patients is really think about who the patient is who's presenting themselves. So if you've got a patient who has disease manifestations that are really being driven by eosinophils, I would definitely think about interleukin-5 blockade. On the other hand, if I have a patient who has, say, palpable purpura, for example, or something that looks much more vasculitic, Patient with arthritis as well, you want to think about more traditional immunosuppressive therapies like methotrexate or azathioprine. Rituximab might be used for patients who are more refractory than that. Glucocorticoid monotherapy is a treatment that's often used more frequently, I think, in France, where they do a lot of research in EGPA. I think in the United States, because we're concerned about glucocorticoid sparing effects, we're much more likely to use glucocorticoids in concert with another drug.
Also, things have evolved a little bit over time, right, as these therapies have emerged. And just one other point I want to make about the acute severe management of EGPA. Those patients were excluded from both the MIRA and Mandara trial. It doesn't mean that they may not be, that
Sure.
they're not effective, but we just didn't study them. But what's interesting to me is that the other therapies are included in the guidelines, although they've never been studied either in acute severe EGPA. So you have to balance that, and it's more based on clinical experience and experience in other vasculitides.
I am happy to say that, like a lot of rheumatology, is an eminence-based medicine recommendation, but you have to start somewhere. I'll also mention as a side, we never talk about the fact that rituximab makes no sense pathophysiologically for an eosinophil-mediated diagnosis. And the reason why we do this, you have to be at least my age to know this. Back in the days of the giants, we only had TNF inhibitors, which don't really help for ANCA-associated vasculitis. And then the next biologic we had was rituximab. So a lot of us had these patients who were flaring after treatment with cyclophosphamide. We had nothing else to offer. So we just threw rituximab at them because it was the only drug that we had on the shelf, and it did seem to help. So we have a lot of clinical experience indicating that rituximab can be helpful for patients who have, for example, eosinophilic myocarditis. What the mechanism of action is, though, I don't think is terribly clear. In terms of management strategies, remember, if you have someone on cyclophosphamide, you cannot leave them on cyclophosphamide forever. Patients top out after 6 months, but often nowadays we're trying to treat patients with only 3 or 4 months of cyclophosphamide. After that, you're going to transfer them to a more conventional DMARD like methotrexate, azathioprine, mycophenolate mofetil, something like that. For patients who have a relapsing disease after treatment with either rituximab or cyclophosphamide, the recommendation from the ACR Vasculitis Foundation guidelines is to then treat with rituximab. That's actually extrapolated from the RAVE trial, which is the trial that led to FDA approval for rituximab for GPA and MPA. It's based on the observation that patients who had previously been treated with cyclophosphamide had an augmented response to rituximab. So previous treatment with cyclophosphamide seemed to get these patients to respond even better to rituximab therapy. Also, the recommendation for treatment with rituximab in that case is to minimize cyclophosphamide exposure. For patients with non-severe disease who are relapsing on a conventional DMARD, the recommendation is to add interleukin-5 blockade. I think we could also add in interleukin-5 receptor blockade as well. So benralizumab, I think, would be widely accepted by people who are following the guidelines. For patients who have a non-severe disease relapse while on a biologic therapy, that ends up falling into more of the shared decision-making. I don't know if there's a straightforward answer in those cases, and it probably does have to be individualized. So now we'll move on to some patient cases.
All right, so I can read the first case here. So this is John. He is a 52-year-old man. He has chronic rhinosinusitis with nasal polyposis. He has severe asthma, and he's been diagnosed with ANCA-negative EGPA. He has had a history of pericarditis related to his EGPA, and he's required multiple rounds of induction therapy. It sounds like with complications of relapse. He currently is on 7.5 milligrams per day of prednisone as well as cyclophosphamide, and that has allowed him to get into remission. He is also on, looks like an intranasal and inhaled corticosteroid and a long-acting beta agonist as well as a muscarinic agonist. So based on this information, what would be your strategy for John's remission maintenance? So obviously we cannot keep him on cyclophosphamide forever. What do you do in the situation with a patient like John?
Yeah, so you want to get them off of cyclophosphamide, and you want to get them down to lower doses of prednisone. He's ANCA negative, and you could argue that his pericarditis might put him more in a severe category. But I think this type of patient would be very reasonable to add on an anti-IL-5 based therapy. Some might, historically, from a rheumatology perspective, might switch him to azathioprine or mycophenolate or methotrexate. My first choice would be, based on the MIRA trial and the Mandara trial, I'd switch him to I'd add on an anti-IL-5 therapy, stop the cyclophosphamide, and give him some time, and then very slowly taper down his prednisone dose in very small increments. Phil, what would you do?
The other thing I'd mention is that NIAMs, when they see a patient with an idiopathic eosinophilic myocarditis, they actually primarily treat with interleukin-5 blockade. They feel like it's very effective for those patients. So I think in this particular case, there's a good argument to give this patient an interleukin-5 blocker of some sort. I think as rheumatologists, we might also give them a little bit of azathioprine or methotrexate just to be safe. But I think that interleukin-5 blockade is certainly a very reasonable strategy for these patients.
I think the goal of azathioprine and even cyclophosphamide in these kinds of patients is really to suppress the bone marrow. And if they're ANCA negative, it's really to prevent the production of eosinophils. And you can do that just as well by giving an anti-IL-5. It's probably safer, less toxic than cyclophosphamide, certainly, and probably less toxic than azathioprine.
Yeah. I think there's less clinical comfort among rheumatologists with not using cyclophosphamide in patients with severe disease. That said, I agree that there's a lot of data indicating that interleukin-5 blockade is incredibly effective for treating eosinophilic diseases of all sorts.
There might be access issues to getting the drug in the acute setting. It's important to recognize as well.
So Mike, let me ask you, if you treated with IL-5 therapy, de-escalated the cyclophosphamide, say the relapse came back, pericarditis comes back, would you switch IL-5 agents? Would you think then about adding a DMARD? How would you approach that?
Yeah, I think, I would look at the biomarkers and I would look at the overall big picture. If the eosinophil count is sufficiently low, I don't think that there is necessarily a benefit of switching between anti-IL-5 therapies. My goal would be to probably give an agent that lowers eosinophils to a greater degree. I would probably, if that patient relapsed, I'd think about adding on another immunosuppressive therapy to that patient rather than switching.
Sure. Okay. Let's go to our next case. This is Carol. She is a 68-year-old woman. She has some comorbidities. So she has coronary artery disease. She's had an MI. She has diabetes. She has asthma and COPD. She has ANCA-positive EGPA, and she's been in remission on methotrexate for a few years. She comes to clinic for a follow-up visit, and she's reporting, sounds like new difficulty lifting her foot when she walks. She feels like it is slapping on the ground, and she notes numbness, tingling, and hypersensitivity to touch around her foot. So the question here is, what are you most concerned about during this follow-up visit with Carol, and what would be your next steps and recommendations? Why don't we start with you, Phil?
Thank you. So the first thing I would do is make sure that she didn't slip a disc, because she is 68 years old, and why not? So remember that monorized multiplex is a painful condition, whereas like a slipped disc is going to be painless. You're also going to assume that patients who have got a slipped disc are going to have hyperreflexivia. So it's a relatively easy way to start thinking about these patients clinically. In this particular case, though, I think monorized multiplex is the likely diagnosis. And for these patients, I think most of us would probably treat with rituximab or cyclophosphamide. The neurologists used to be much more nervous about using rituximab for monorized multiplex, but I think now they're supportive of it just because the safety profile is so much better than cyclophosphamide.
Yeah, and what would you do in terms of getting nerve conduction studies and doing sort of the neurologic workup? Would you delay treatment to get those things? Or,
oh, no.
And what about, is there a role for biopsying, doing nerve biopsies for those patients? And what about EMG? And, I lump usually EMG and nerve conduction studies together.
Yeah, maybe I'm not such a good doctor to ask that particular question to. So I feel like...
Oh, let's ask you.
So I would pursue EMG. Again, as Phil mentioned, there's a differential here. Of course, if you're suspecting mononeuritis multiplex, you treat it and you don't wait, but an EMG can still help us identify other mimics or causes like radiculopathy. I think if a patient already has pretty solid ANCA-positive EGPA, it's a convincing story, and an EMG or even the clinical picture is suggestive of mononeuritis multiplex, I don't see a reason to go for biopsy at that point. It's still an invasive procedure, and only perhaps if they weren't responding as I would expect them to immunosuppressive therapy, then I might consider biopsy. Of course, if she did not have the diagnosis of EGPA already, or was ANCA negative, for example, and you were wondering about a diagnosis, I have definitely sent people for sural nerve biopsy to help confirm the diagnosis in the first place.
And what about the role of just, as opposed to giving rituximab for this patient, just giving them high-dose IV corticosteroids in the acute setting? Is there a role of doing that versus rituximab in the acute setting? Are there data to support doing one versus the other?
I'm not sure if they're great data. I think that the issue, though, is the concern that if you treat with glucocorticoid monotherapy, that patient will have a recurrence relatively quickly as you taper the prednisone. In my patients with EGPA with severe manifestations, I can see them relapse with prednisone doses as high as 40 milligrams. So relapses can be pretty aggressive in my patients. So I would probably co-treat with something else. I think that with regards to the biopsy yield for mononeuritis multiplex is only as high as 70%, and in rheumatology populations, it can be as low as like 20 or 30%. It's the reason why I would hesitate to get a biopsy, because if mononeuritis multiplex is the most likely diagnosis, there's not a lot on the biopsy that's going to change my mind about treatment.
And one last question. In the older days, people would use plasmapheresis in some of these patients. Is there any role? There were several studies from, I think, Japan looking at the role of plasmapheresis in these kinds of patients.
Yeah, the rheumatologists have kind of become very cold about plasma exchange for ANCA-associated vasculitis in general, so we tend not to use it as often. I would say that there's not a lot of clear data specifically about mononeuritis multiplex. Some of you may have been at the ANCA session earlier where someone raised a question about the use of plasma exchange with mononeuritis multiplex. So some people feel very strongly about it. I don't think there's great data about its utility.
The data are sort of soft. In this patient, for the record, I would increase the steroids and give rituximab. That's what I would do.
Sounds like we're all in agreement then. Okay. Another diagnostic challenge. So this is David now. He is a 50-year-old man. He has EGPA, and his manifestations have been asthma, allergic rhinitis, and mononeuritis multiplex. He was initially treated with cyclophosphamide, and since his EGPA diagnosis, he's been maintained on prednisone 10 milligrams daily, but has continued to experience asthma attacks requiring higher doses of systemic glucocorticoids. So which of the following would you say is the most optimal approach for David to start cyclophosphamide 2 mg per kg by mouth daily, to start methotrexate 20 milligrams by mouth weekly, to add an IL-5 or 5 receptor biologic subcutaneous monthly, or to continue his current medications? And it looks like most people got the correct answer. So for a patient with EGPA who's unable to get off prednisone due to asthma, adding an IL-5 or 5 receptor biologic monthly would be the optimal approach.
They've been approved for asthma, and they reduce exacerbations.
So another discussion point here. Tell me a little bit, we've kind of got into it already, but tell me about how you would approach switching rituximab cyclophosphamide to a IL-5 biologic. Is there any situation where you're not switching to an IL-5 agent and you're switching to a DMARD or a combination, or is your approach more IL-5 monotherapy?
I'm an IL-5 believer, and I think the data are pretty clear from both the MERIT trial and the Mandara trial that they're safe and effective strategies. I can't really think of any circumstance in which I wouldn't do it, and I don't have a problem. We don't have good data in terms of switching because rituximab patients were excluded, cyclophosphamide patients were excluded, but generally I would just add on the anti-L5 biologics. Phil?
Yeah, I'm concerned mainly about the patients who have like classic vasculitic syndrome. Like if they have glomerulonephritis, for example, I'm not convinced that interleukin-5 blockade treats glomerulonephritis. And I would tend to use it in conjunction with, say, azathioprine or methotrexate after treatment of cyclophosphamide. That's my personal belief. I don't know if there's proof one way or the other.
Yeah, we've had debates on that. And
yes.
I think that we recognize that we're in a data-free zone. And I think we try one and we see how it does, and we try another and we see how it does.
And in terms of the question of tapering prednisone, so let's take starting with a patient with non-severe manifestations. When you start an IL-5 agent, what does your prednisone tapering schedule typically look like?
Yeah, so it really depends on what their starting point is, and I give them time. The data for different tapering strategies is variegated as the number of rheumatologists and pulmonologists out there. If a patient's on 40 milligrams, I'll go down in 5 milligram increments till they get down to 20, and then I'll go down in 2.5 milligram increments till they get down to 10, and then I'll go down in 1 to 2 milligram increments, and it will vary in terms of the time frame depending on the patient. It'll range from every 5 to 14 days to even longer, but really it's guided by how the patients are feeling.
Yeah.
So getting into some key takeaways from today. So we heard that EGPA is difficult to diagnose and it's rare. It presents in a lot of different ways and the symptoms can be severe. So we have to keep a high index of suspicion for EGPA, and even when we do diagnose this, it can be challenging to manage. We heard that patients themselves experience a huge disease burden or symptom burden, and in severe cases are at risk for a higher mortality, often driven by cardiovascular involvement in particular. And we've talked a lot about how biologic therapy, these IL-5 agents, have demonstrated good efficacy. They're very safe in the treatment of EGPA and might allow us to get these patients off of glucocorticoids, something we are always trying to do because, as Mike mentioned, of the myriad of different short-term and long-term side effects of that treatment. And I think you've heard here, we're all in agreement that a multidisciplinary approach from a number of different specialists is really crucial to caring for EGPA patients who will have involvement, typically of numerous organ systems throughout. So we will go through some post-test questions now. They will be the same as the beginning pre-test questions, and you can go ahead and answer on your clickers. So this is: which of the following immune cells and cytokines play an integral role in the pathophysiology of EGPA and are a target of the currently available biologic therapy? Eosinophils and IL-5, neutrophils and interferon gamma, macrophages and IL-1, or natural killer cells and IL-3.
We'll be very upset if there isn't a 100% response right here. Another takeaway from this discussion is that there's still controversies in the management of these patients, and we need to do more clinical trials and generate more data. 100%, great. Look at that, we did our job.
Nice. All right, post-test question 2. In a patient who presents with eosinophilia and late-onset asthma, which of the following is most likely to increase your clinical suspicion for EGPA? Is it hematuria, mononeuritis multiplex, otitis media, or a positive test for PR3? And a majority of folks picked the correct answer, which is mononeuritis multiplex. In the phase 3 Mandara study, which of the following is true regarding the 2-year efficacy of benralizumab in patients with relapsing or refractory EGPA? Benralizumab is superior to placebo for induction of remission. Switching from benralizumab to mepolizumab enhanced blood eosinophil depletion and oral corticosteroid sparing. Switching from mepolizumab to benralizumab enhanced blood eosinophil depletion and steroid sparing. and benralizumab was superior to reslizumab for induction of remission. Awesome. Again, majority of the people selected the correct answer, which was that switching from mepolizumab to benralizumab enhanced blood eosinophil depletion and steroid sparing. Okay, Sarah is a 46-year-old woman who has a 10-year history of asthma and was recently diagnosed with ANCA-negative EGPA. She is clinically stable on 100 milligrams azathioprine daily, but unable to taper below 15 milligrams per day of prednisone. Which of the following would you recommend to Sarah at this time to maintain her current medications? Add a biologic with the goal of tapering prednisone, add a biologic and continue current medications, or start cyclophosphamide with the goal of tapering prednisone? Wonderful. Majority of folks picked the correct answer to add a biologic and continue current medications. Or sorry, add a biologic and continue prednisone. Approximately how often will you now recommend biologic therapy for patients with EGPA? Never, 25% of the time, 50% of the time, 75% of the time, 100% of the time, or you don't manage patients with EGPA? And it looks like a bit of a spectrum here.
But at least the numbers went up for
It did.
75 to 100%. It's good. Great.
Okay. All right, so I think now we have some audience questions that we'll go ahead and
If you have any other questions, raise your hand, write them down on a card, and someone will pick them up. So just wave your hand, and we'll have someone pick them up. But we did get some questions. Here's a good question. Once a patient with EGPA starts a biologic, will they ever be able to stop, or are they lifelong? Really good question, and it's not a question that's really been looked at either in EGPA or in asthma where these biologics are used. I recently wrote an article about what to do when patients achieve remission in asthma, published in the Journal of Allergy Clinical Immunology. And there's different options there. You can continue, and that's sort of the default, is to continue the biologic lifelong. Another option is to stop the biologic. Most of those patients actually have increased risk of relapses. Dr. Most over there, I think, published an abstract a couple of years ago that showed that around 50% of patients did okay, but 50% didn't, and so that's an important consideration. Another option is to increase the dosing interval in an off-label manner. It's something I actually do once a patient's achieved remission for a year. And then there are other special circumstances where you can also wait and see if there's other therapies that are emerging. I don't know if you have any other thoughts in that regard, either of you.
I'm waiting for depemokimab.
So that's another ultra-long-acting anti-IL-5 therapy. You have a question over there?
Yeah, I have a question. Do all patients with ANCA-positive EGPA eventually develop vasculitis, or could they stay in the eosinophilic phase? And that's a great point. A lot of patients with EGPA, regardless of ANCA positivity or not, will never develop a true vasculitis. It actually is one of the diagnostic issues that comes with making a diagnosis of EGPA, and one of the reasons why the 3 phases of Churg-Strauss that we talked about previously have somewhat fallen out of favor. It just acknowledges that not all patients will go through all 3 phases.
Okay. How do you manage pediatric EGPA? Can either anti-IL-5 or anti-IL-5 receptor biologic be utilized? Pediatric EGPA is exceedingly rare. There are around 25 case reports in the literature so it can occur usually in older adolescents. In younger kids, it's very unusual, and I'd look for alternative diagnoses, but you can have eosinophilic pneumonia. The anti-IL-5s can be utilized. I don't know if there's a specific labeling in that patient population in terms of age, but it's something to consider from a safety perspective. Here's another one. Is there a role for genetic testing or next generation sequencing after diagnosis of EGPA? Could results improve prognostication and guide treatment decision making? Have any thoughts in that regard?
I don't think we're there yet. I think it's an interesting research question, but I'm not sure if advanced sequencing would actually help with terms of management of prognosis.
Yeah, I think the role of genetic testing is to try to identify other causes of hypereosinophilia. So, you can look for myeloproliferative variants and lymphoproliferative variants that may be associated with hypereosinophilic syndromes that could be targeted. So, for instance, if patients have the FIP1L1 PDGFR alpha fusion protein, they might be a candidate for imatinib, for instance, which has been shown to be effective in those specific patients. Otherwise, I think we're still doing a lot of research to try to identify genetic causes. And the last question, unless anybody from the audience has any questions, does having seasonal or food allergies increase the risk of developing EGPA? There might be some association with food allergies and allergies in general, which are type 2 mediated inflammatory diseases. If you rev up the Th2 profile in an individual and you'll increase IgE, you're also going to increase eosinophils, and so that might put those patients at risk. That being said, I want to thank you all. Unless there's other questions, if there's any other questions, raise your hand. I can't see, but we'd be happy to stay up here for a few minutes and answer any questions. But I want to thank you all for participating tonight, to those in person, those who are online. I thought there was a great discussion, and I want to thank my colleagues for joining us, and remind you to do a post-test, I believe, as well. And maybe there's a clicker. We have to show people anything else. But I also want to thank our sponsors from AstraZeneca, and thank also the CME team for helping put this all together. And thank you all for taking time in your evening to join us. Good. That was good. Good job.
Thank you. Appreciate it.
Enjoyed that.